Soft tissue infections. Q&A. Welcome to today's podcast, where we discuss the main aspects of soft tissue infections. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the management of soft tissue infections. Pause the podcast after each question to attempt answer. Let's begin. Introduction, definitions, classification, and overview. Question: what are skin and soft tissue infections? Answer: skin and soft tissue infections are a group of conditions affecting the skin and underlying tissues, with severity ranging from mild to severe. Question: what characterizes complicated skin and soft tissue infections? Answer: complicated skin and soft tissue infections, such as necrotizing infections and infected pressure ulcers, are associated with considerable morbidity, mortality, and increased healthcare costs. Question: what are the potential complications if skin and soft tissue infections are not recognized and treated early? Answer: failure to identify and treat skin and soft tissue infections early can result in sepsis, organ dysfunction, and widespread infection, presenting serious clinical challenges. Question: how are skin and soft tissue infections classified? Answer: skin and soft tissue infections are classified according to infection depth, anatomic location, and severity of clinical presentation. Question: what terminology has the United States Food and Drug Administration introduced for certain skin and soft tissue infections? Answer: the United States Food and Drug Administration uses the term acute bacterial skin and skin structure infections to describe conditions such as cellulitis, erysipelas, wound infection, and major cutaneous abscesses. Question: what classification system is recommended by the World Society of Emergency Surgery and the Surgical Infection Society Europe? Answer: the World Society of Emergency Surgery and the Surgical Infection Society Europe recommend classifying skin and soft tissue infections based on anatomic location, presence of purulence or necrotizing tissue, and the patient's clinical condition. Question: which organizations collaborated to promote global standards in skin and soft tissue infection management? Answer: the Global Alliance for Infections in Surgery, World Society of Emergency Surgery, American Association for the Surgery of Trauma, and 2 additional societies collaborated to create guidelines for managing skin and soft tissue infections and to promote global standards of care. Question: what is the main focus of this chapter? Answer: this chapter focuses primarily on necrotizing and non-necrotizing skin and soft tissue infections, with attention to significant infections in specific patient populations. Question: why is a focused approach necessary for skin and soft tissue infections? Answer: significant variations in the management and clinical outcomes of skin and soft tissue infections require a focused approach to improve care. Non-necrotizing soft tissue infections. Prevalence, causes, diagnosis, and treatment. Question: how prevalent are non-necrotizing skin and soft tissue infections among hospitalized patients? Answer: non-necrotizing skin and soft tissue infections affect approximately 10% of hospitalized patients and are frequently encountered by general surgeons. Question: what tissues are involved in non-necrotizing skin and soft tissue infections, and what are some examples? Answer: non-necrotizing skin and soft tissue infections are limited to the subcutaneous tissues and include conditions such as erysipelas, impetigo, folliculitis, and various abscesses. Question: what are the main causes of non-necrotizing skin and soft tissue infections? Answer: the primary causes are a compromised skin barrier, resulting from trauma, surgery, or pressure, and weakened host defenses, such as those seen in diabetes, steroid use, or immunosuppressant therapy. Diagnostic workup of non-necrotizing soft tissue infection. Question: what role does imaging play in diagnosing non-necrotizing skin and soft tissue infections? Answer: imaging, including plain radiographs, ultrasound, computed tomography scans, and magnetic resonance imaging, can aid diagnosis but should not delay surgery in critically ill patients. Question: what advantages does ultrasound offer in assessing skin and soft tissue infections? Answer: ultrasound is cost-effective and widely available, providing greater sensitivity than plain radiographs for evaluating deeper components or detecting abscesses in skin and soft tissue infections. Question: what are the limitations of ultrasound in diagnosing skin and soft tissue infections? Answer: ultrasound cannot assess deeper structures and may underestimate the extent of infection. Question: what are the benefits of computed tomography scans in evaluating skin and soft tissue infections? Answer: computed tomography scans offer rapid acquisition, broad availability, ease of interpretation, and superior evaluation of deeper structures compared to ultrasound. Question: what findings on computed tomography scans are typical of skin and soft tissue infections? Answer: typical findings include skin thickening, fat stranding, edema, presence or absence of gas, and sometimes a thickened facial layer. Abscesses appear as ring-enhancing fluid collections. Question: what is the role of magnetic resonance imaging in diagnosing skin and soft tissue infections? Answer: magnetic resonance imaging is especially useful for evaluating soft tissues, offering greater sensitivity for detecting inflammation, fasciitis, myositis, and necrosis. It requires intravenous gadolinium-based contrast. Question: why is determining the need for culture data in non-necrotizing skin and soft tissue infections challenging? Answer: the decision to obtain detailed culture data is complex because routine cultures may not be necessary in all cases and should be tailored to the clinical scenario. Question: what is recommended regarding bacterial cultures for recurrent abscesses? Answer: for recurrent abscesses, it is essential to identify and remove any foreign material, and bacterial cultures should be obtained for species identification and antibiotic susceptibility testing. Question: when should cultures, tissue aspirates, or skin biopsies be performed for cellulitis or erysipelas? Answer: routine cultures, tissue aspirates, or skin biopsies are generally not recommended for cellulitis or erysipelas unless the patient is immunocompromised or exhibits signs of systemic illness. Types and treatment of non-necrotizing soft tissue infection. Erysipelas. Question: what is erysipelas? Answer: erysipelas is a painful, red, swollen skin infection involving the upper dermis, characterized by clearly defined borders. Question: what is the primary cause of erysipelas? Answer: erysipelas is primarily caused by group A beta hemolytic streptococci or other species of streptococcus. Question: how is erysipelas treated? Answer: routine cases are managed with oral antibiotics such as amoxicillin clavulanate or cephalexin. For patients at risk for methicillin-resistant Staphylococcus aureus, trimethoprim sulfamethoxazole, minocycline, or doxycycline may be used. Inpatients may receive cefazolin or amoxicillin clavulanate. Question: what initial treatment is recommended for erysipelas with systemic illness? Answer: intravenous antibiotics targeting both Staphylococcus aureus and streptococci should be administered immediately in patients with systemic illness. Question: when should coverage for methicillin-resistant Staphylococcus aureus be considered in erysipelas? Answer: coverage with vancomycin or linezolid should be considered based on risk factors. Although community-acquired methicillin-resistant Staphylococcus aureus is rare in this setting. Question: what is the typical duration of treatment for erysipelas? Answer: most episodes resolve within 5 days of antibiotic therapy, but treatment may be extended to 10 days if symptoms persist. Furuncles and Carbuncles. Question: what are furuncles? Answer: furuncles are pus-filled collections involving hair follicles, with suppuration extending through the dermis into the subcutaneous tissue. Question: what are carbuncles? Answer: carbuncles occur when infection involves multiple adjacent hair follicles, resulting in a coalescent inflammatory lesion with purulent drainage. Question: how are furuncles and carbuncles treated? Answer: the primary treatment is incision and drainage, and antibiotics are reserved for cases with extensive surrounding cellulitis. Cutaneous abscesses. Question: what is a cutaneous abscess? Answer: a cutaneous abscess is a painful, pus-filled collection within the skin, often accompanied by surrounding redness and swelling. Question: what is the typical treatment for simple cutaneous abscesses? Answer: simple abscesses are usually treated with incision and drainage. Antibiotics may be considered for complex cases or when specific criteria are present. Question: what antibiotic options are recommended for cutaneous abscesses? Answer: for simple abscesses, amoxicillin clavulanate, cephalexin, doxycycline, trimethoprim sulfamethoxazole, or clindamycin are recommended. Severe infections may require vancomycin, linezolid, tigecycline, daptomycin, ceftaroline, or tilavincin. Cellulitis. Question: what is cellulitis? Answer: cellulitis is a bacterial skin infection affecting the deeper dermal layer and subcutaneous fat. Question: What risk factors increase susceptibility to cellulitis? Answer: obesity, diabetes, fragile skin, pre-existing skin conditions, and compromised host defenses increase the risk of developing cellulitis. Question: what are the common symptoms and signs of cellulitis? Answer: the typical symptoms and signs include erythema, warmth, lymphangitis, pain, and purulent discharge. Streptococci and Staphylococcus aureus are the most frequent pathogens. Question: how is typical cellulitis treated? Answer: typical cellulitis is treated with oral amoxicillin clavulanate or a narrow-spectrum beta-lactam antibiotic for 5 to 10 days. Question: how is purulent cellulitis managed? Answer: purulent cellulitis is treated with incision and drainage. Question: what are the recommended treatments for severe cellulitis? Answer: severe cellulitis is managed with cefazolin for inpatient therapy, piperacillin tazobactam for immunocompromised patients, and clindamycin for patients with beta-lactam allergy. Question: why are fluoroquinolones not recommended for cellulitis? Answer: fluoroquinolones are not recommended due to safety concerns, including tendinitis, neuropathy, and central nervous system effects. Question: what is the role of tetracycline derivatives in cellulitis treatment? Answer: tetracycline derivatives are effective against multi-drug-resistant pathogens but are considered second-line agents. Question: how long should antibiotics typically be administered for cellulitis? Answer: antibiotics are usually given for 5 days, but the duration may be extended based on the patient's response and the severity of infection. Necrotizing soft tissue infections. Definition, types, diagnosis, and management. Question: what is a necrotizing soft tissue infection? Answer: necrotizing soft tissue infection is a rapidly progressing infection affecting any or all layers of soft tissue, characterized by tissue necrosis and high mortality. Question: what conditions are included under necrotizing soft tissue infections? Answer: necrotizing soft tissue infections include necrotizing cellulitis, fasciitis, myositis, Fournier gangrene, and clostridial myonecrosis. Question: what is the typical clinical presentation and management of necrotizing soft tissue infections? Answer: necrotizing soft tissue infections usually present with rapid progression, tissue necrosis, and high rates of sepsis, requiring immediate surgical intervention and adjunctive therapies. Question: why is it difficult to establish an early diagnosis of necrotizing soft tissue infections? Answer: early diagnosis is challenging due to the rarity of the condition and lack of familiarity among clinicians. Question: what is the estimated incidence rate of necrotizing soft tissue infections in the United States? Answer: the estimated incidence is between 1,000 and 1,500 cases annually, but this may be underreported. Question: what factors may contribute to an apparent increase in necrotizing soft tissue infections? Answer: the increase may be due to heightened awareness, an aging population, or improved survival rates among immunosuppressed individuals. Clinical manifestations of necrotizing soft tissue infection. Question: what is the rate of misdiagnosis for necrotizing soft tissue infections? Answer: up to 71% of necrotizing soft tissue infections are misdiagnosed initially. Question: what are the consequences of misdiagnosing necrotizing soft tissue infections? Answer: misdiagnosis can result in inadequate treatment, delayed surgical intervention, and increased mortality. Question: how can necrotizing soft tissue infections present clinically? Answer: they can present either with rapid onset and severe symptoms or with slow, ambiguous symptoms, making diagnosis challenging. Types of necrotizing soft tissue infection. Question: how are necrotizing soft tissue infections categorized? Answer: necrotizing soft tissue infections are divided into 3 distinct categories, with type 1 being the most common. Question: what characterizes type 1 necrotizing soft tissue infection? Answer: type 1 is a polymicrobial infection involving gram-positive, gram-negative, and anaerobic organisms, with an insidious presentation often affecting immunocompromised patients or those with comorbidities such as diabetes, renal failure, or peripheral vascular disease. Question: what factors influence the severity of necrotizing soft tissue infections? Answer: severity is influenced by patient demographics and the specific microorganisms involved. Question: what characterizes type 2 necrotizing soft tissue infection? Answer: type 2 is a monomicrobial infection, Most commonly caused by group Streptococcus, especially toxin-producing strains, resulting in systemic toxicity. Question: what is the typical patient profile for type 2 necrotizing soft tissue infection? Answer: type 2 often affects younger and healthier individuals, typically with a history of trauma, surgery, or intravenous drug use. Question: how does the pathogenesis of type 2 necrotizing soft tissue infection result in systemic toxicity? Answer: exotoxins produced by the causative organisms trigger T-cell activation and a cytokine cascade, leading to fulminant systemic toxicity. Question: what is type 3 gas gangrene, and what causes it? Answer: type 3 gas gangrene is caused by Vibrio vulnificus or species of Clostridium. Question: how common is clostridial myonecrosis and what trends are observed? Answer: clostridial myonecrosis is relatively uncommon, but infections caused by gram-negative and multi-drug resistant organisms are increasing. Question: what is the essential treatment for all types of necrotizing soft tissue infections? Answer: immediate surgical intervention is required for all types due to the risk of severe infection. Diagnosis of necrotizing soft tissue infection. Question: what challenges exist in diagnosing necrotizing soft tissue infections early? Answer: superficial signs may be subtle and masked by milder infection symptoms, making early diagnosis difficult. Question: what specific signs may indicate necrotizing soft tissue infection, and how reliable are they? Answer: crepitus, skin necrosis, and bully are indicative but occur in less than 40% of cases, limiting their reliability. Question: how effective are risk calculators in diagnosing necrotizing soft tissue infections? Answer: risk calculators such as the Fournier Gangrene Severity Index, the EULUDAG-Fournier Gangrene Severity Index, and the Laboratory Risk Indicator for Necrotizing Fasciitis have limited sensitivity and accuracy in early diagnosis and outcome prediction. Question: what imaging modalities are used for diagnosing necrotizing soft tissue infections? Answer: plain radiographs, computed tomography, magnetic resonance imaging, and ultrasound are utilized for diagnosis. Question: what is the role of computed tomography in diagnosing necrotizing soft tissue infections? Answer: computed tomography is more effective than plain radiographs in detecting gas in soft tissues, which is a sign of necrotizing infection. Question: what limitations exist for imaging in necrotizing soft tissue infection diagnosis? Answer: imaging should not delay treatment, and a negative result does not exclude necrotizing infection. Question: what surgical procedure is performed when necrotizing fasciitis diagnosis is unclear? Answer: a 2 cm full-thickness elliptical excision of soft tissue is performed for further investigation. Question: what findings are sought during tissue examination for necrotizing soft tissue infection? Answer: excised tissue is inspected for necrosis, purulent fluid, discoloration, or non-contractile muscle, though these findings may not always be present. Question: how can diagnosis be confirmed when findings are equivocal? Answer: a full-thickness biopsy with fresh frozen section and gram stain may be used for confirmation. Question: what alternative method is available for diagnosis if biopsy is unavailable? Answer: the push test can be used to assess tissue resistance and guide treatment. Question: what sample should be collected for diagnosing necrotizing soft tissue infection? Answer: deep tissue, fluid, and blood cultures are helpful, while superficial samples should be avoided. Question: what emerging diagnostic tools show promise for necrotizing soft tissue infection? Answer: metagenomic next-generation sequencing may detect a broader range of pathogens, but it is not widely available. Treatment of necrotizing soft tissue infection. Surgical debridement. Question: what is the primary treatment modality for necrotizing soft tissue infection? Answer: surgical debridement is the primary treatment. Question: how does timing and extent of debridement affect outcomes in necrotizing soft tissue infection? Answer: early and aggressive debridement, performed within 6 hours of diagnosis, significantly improves outcomes and reduces mortality. Question: what is involved in the surgical procedure for necrotizing soft tissue infection? Answer: generous incisions are made and all infected or necrotic tissue is removed. Some surgeons also excise a margin of normal tissue to ensure negative margins. Question: what are the benefits and requirements of a skin-sparing approach in debridement? Answer: a skin-sparing approach may offer improved cosmetic and functional outcomes but requires wide undermining to remove necrotic tissue. Question: When may amputation be necessary in necrotizing soft tissue infection? Answer. Amputation may be required for affected extremities to achieve healthy margins, based on clinical judgment and intraoperative findings. Question. How is skin viability assessed during debridement? Answer. Some studies use zones to guide debridement, evaluating skin viability for optimal outcomes. Question. Where are patients typically managed following debridement for necrotizing soft tissue infection? Answer. Patients are typically managed in the intensive care unit. Question. What is interval debridement, and when is it performed? Answer. Interval debridement is repeated until no further necrosis or infected tissue remains. Question. Is there high-level evidence to guide timing or frequency of redebridement? Answer. No high-level evidence exists to guide the timing or frequency of redebridement. Question. How does debridement frequency affect outcomes? Answer. Earlier studies suggest short-interval redebridement improves outcomes, but recent findings indicate a single debridement may suffice if all necrotic tissue is removed initially. Question. What factors should guide ongoing debridements? Answer. Patient physiology and signs of ongoing tissue ischemia should determine the need for further debridements. Question. How should wounds be managed post-debridement? Answer. Thorough wound evaluation through bedside checks is essential to determine if further debridement is needed. Antimicrobial treatment. Question. What initial antimicrobial treatment is recommended when necrotizing soft tissue infection is suspected? Answer. Broad-spectrum antibiotics effective against gram-positive, gram-negative, and anaerobic organisms, including methicillin-resistant Staphylococcus aureus, should be started immediately. Question. What empiric antimicrobial regimen is typically recommended for necrotizing soft tissue infection? Answer. Treatment usually involves a broad-spectrum beta-lactam, an anti-methicillin-resistant Staphylococcus aureus agent, and clindamycin for its toxin-neutralizing properties. Question. What is the specific recommendation for group Streptococcus infections? Answer. For necrotizing soft tissue infection caused by group Streptococcus, guidelines strongly recommend combination therapy with penicillin and clindamycin, even in the absence of toxic shock syndrome. Question. How should carbapenem use be guided in antimicrobial therapy? Answer. The use of carbapenem should be determined by local antibiograms and individual patient risk factors for resistant gram-negative bacilli. Question. What patient risk factors should be considered when choosing antibiotics for necrotizing soft tissue infection? Answer. Recent exposure to beta-lactam antibiotics, hospital-acquired infection, and a history of extended-spectrum beta-lactamase infection are important risk factors. Question. What trends are observed regarding resistance and anaerobic bacteria in necrotizing soft tissue infection? Answer. Multi-drug resistant organisms, including extended-spectrum beta-lactamase-producing bacteria, are emerging, and anaerobic bacteria are often underappreciated, particularly in Fournier gangrene. Question. What challenges exist in antibiotic delivery for necrotizing soft tissue infection? Answer. Tissue necrosis and altered perfusion can impair antibiotic delivery to affected tissues. Question. How does septic shock affect antibiotic effectiveness? Answer. Vasodilation, capillary leak, and fluid extravasation during septic shock may result in low plasma levels of hydrophilic antibiotics, affecting their efficacy. Question. What dosing considerations may be necessary for optimal bactericidal activity? Answer. Prolonged or continuous infusions, higher frequency dosing, and therapeutic drug monitoring may be required for optimal bactericidal activity. Question. When should antibiotics be de-escalated in necrotizing soft tissue infection? Answer. Antibiotics should be de-escalated when the patient shows clinical improvement and culture results are available. Question. How long should antimicrobial therapy be continued for necrotizing soft tissue infection? Answer. Therapy should continue until no further debridement is necessary and the patient is clinically stable for at least 48 hours. Question. Are shorter courses of antimicrobial therapy effective for necrotizing soft tissue infection? Answer. Shorter courses, less than 7 days, appear equivalent to longer courses and should be considered. Adjuvant therapy. Question. What role does early goal-directed resuscitation play in necrotizing soft tissue infection? Answer. Early goal-directed resuscitation is often necessary throughout the perioperative period, especially for patients with sepsis or septic shock. Question. Why is close monitoring essential in the management of necrotizing soft tissue infection? Answer. Close monitoring is crucial for early detection and management of clinical decompensation and organ failure. Question: what is the priority in source control for necrotizing soft tissue infection? Answer: achieving source control should take precedence over complete metabolic reversal, as it is vital for successful treatment. Question: what is the current role of intravenous immunoglobulin therapy in necrotizing soft tissue infection? Answer: although initially promising, randomized trials have not demonstrated significant benefits, and intravenous immunoglobulin is now infrequently used. Question: what is the proposed role of hyperbaric oxygen therapy in necrotizing soft tissue infection? Answer: hyperbaric oxygen therapy is suggested as an adjunctive treatment to increase tissue oxygenation, but its efficacy is not well established. Question: what are the potential benefits and limitations of hyperbaric oxygen therapy? Answer: potential benefits include reduced mortality and fewer debridements, but evidence is insufficient for routine use. Question: what is the role of immune modulators in necrotizing soft tissue infection treatment? Answer: agents such as riltesimide may improve organ failure scores but are not yet widely accepted in clinical practice. Wound care and reconstruction, approaches and multidisciplinary management. Question: how should wounds be managed following necrotizing soft tissue infection? Answer: wet to dry gauze dressings, changed once or twice daily, are recommended for wound management. Question: how are perineal necrotizing soft tissue infections managed to prevent wound contamination? Answer: a loop colostomy is used to divert the fecal stream and prevent contamination. Question: what is the role of negative pressure vacuum dressings in wound care? Answer: negative pressure vacuum dressings are used after infection resolution and debridement to aid healing and prepare the wound for autografting or dermal matrix placement. Question: what is required for long-term management of necrotizing soft tissue infection? Answer: long-term management requires a multidisciplinary approach beyond the operative period. Question: what morbidity and complications are common in patients with necrotizing soft tissue infection? Answer: chronic pain, poor functional outcomes, and complications such as ventilator-associated pneumonia and acute kidney injury are common. Question: what care setting is optimal for patients with necrotizing soft tissue infection? Answer: centers equipped with critical care, wound care, nutrition, and physical and occupational therapy capabilities are ideal for achieving the best long-term outcomes. Other types of skin and soft tissue infections. Diabetic foot infections. Question: what is the relationship between diabetes and foot complications? Answer: diabetes is associated with a high rate of foot problems, which are a major cause of disability worldwide. Question: how common are foot ulcers among individuals with diabetes? Answer: up to 1/3 of individuals with diabetes will experience a foot ulcer in their lifetime. Question: what is the risk of infection and mortality in diabetic foot ulcers? Answer: over half of diabetic foot ulcers become infected, resulting in increased morbidity, mortality, and reduced quality of life. Question: how do diabetic foot ulcers typically develop, and what factors increase risk? Answer: diabetic foot ulcers often begin with a break in the skin, and risk is increased by cardiovascular and renal disease, microvascular injury, and malnutrition. Question: how severe can diabetic foot infections be? Answer: diabetic foot infections can range from mild cellulitis to gangrene. Question: how does autonomic neuropathy affect the development of diabetic foot ulcers and infections? Answer: autonomic neuropathy contributes by causing blood shunting, loss of sweat and oil glands, and reduced pain response, leading to ulceration and infection. Question: what is the recurrence rate of diabetic foot ulcers? Answer: nearly 50% of diabetic foot ulcers recur within 1 year, and over 90% within 10 years. Question: what proportion of diabetic foot ulcers progress to osteomyelitis? Answer: up to 15% progress to osteomyelitis, which often requires amputation. Question: how does major amputation affect 5-year survival in diabetic patients? Answer: 5-year survival drops from 70% to 43% after major amputation, likely due to worsening cardiovascular and renal disease. Question: what pathogens are commonly involved in diabetic foot infections? Answer: diabetic foot infections are often polymicrobial, involving staphylococcal, streptococcal, pseudomonal, and anaerobic microorganisms. Question: what are the limitations of the Wagner classification system for diabetic foot infections? Answer: The Wagner system does not account for neuropathy or vascular disease, making it difficult to distinguish between infectious and ischemic lesions. Question: what classification system is recommended for diabetic foot infections? Answer: the International Working Group on the Diabetic Foot and the Infectious Diseases Society of America have developed a more recent and validated classification system. Question: how is diabetic foot infection diagnosed? Answer: diagnosis is made clinically through physical examination. Question: what laboratory tests support the diagnosis of diabetic foot infection? Answer: while no definitive laboratory value exists, elevated C-reactive protein and erythrocyte sedimentation rate may support the diagnosis. Question: what imaging modalities are useful in diagnosing diabetic foot infection? Answer: plain radiographs detect foreign bodies and gas. Computed tomography identifies deep abscesses, and magnetic resonance imaging enables earlier diagnosis of osteomyelitis. Question: what are the primary goals in treating diabetic foot infections? Answer: goals include maintaining normal blood glucose, keeping the wound environment moist, treating cellulitis and osteomyelitis with systemic antibiotics, debriding necrotic tissue, and offloading the affected area. Question: why is early debridement important in diabetic foot infections? Answer: early debridement is associated with lower rates of major amputation and improved wound healing. Question: when is urgent surgical debridement required for diabetic foot infections? Answer: urgent surgical debridement is necessary for severe or necrotizing infections, deep abscesses, compartment syndrome, or limb ischemia. Question: how long should antibiotic treatment be administered for diabetic foot infections? Answer: mild infections require 1 to 2 weeks of antibiotics, while moderate to severe infections, especially with compromised blood flow, may require longer treatment. Question: what is the recommended duration of antibiotic therapy for osteomyelitis in diabetic patients? Answer: treatment typically lasts 6 weeks, but may be extended if underlying conditions are not addressed. Question: how long should follow-up be conducted to determine remission of diabetic foot infection? Answer: at least 1 year of follow-up is recommended, with consideration of alternative diagnosis if infection persists. Question: what treatment strategies are used for diabetic foot ulcers? Answer: treatment includes surgical debridement, antimicrobial therapy, improving blood flow, and optimizing oxygen delivery. Question: how can transcutaneous oxygen measurements assist in diabetic foot ulcer management? Answer: transcutaneous oxygen measurements can be used to risk stratify patients with diabetic foot ulcers. Question: what is the role of hyperbaric oxygen therapy in diabetic foot ulcer treatment? Answer: hyperbaric oxygen therapy may accelerate healing and lower the risk of amputation, but its effect on infection control is uncertain. Question: why is an interdisciplinary approach essential for treating diabetic foot infections? Answer: an interdisciplinary approach is vital to address the complex needs of patients with diabetic foot infections. Question: who should be included in the interdisciplinary team for diabetic foot infections? Answer: the team should include endocrinologists, surgeons, podiatrists, pharmacists, dietitians, infectious disease specialists, and wound care specialists. Question: what components should treatment of diabetic foot infections include? Answer: treatment should involve daily wound care, surgical intervention, antibiotics, and frequent follow-up visits. Infected deep tissue and pressure injuries. Question: what is a pressure injury? Answer: a pressure injury is localized tissue necrosis caused by prolonged pressure on soft tissue between a bony prominence and an external surface. Question: what causes pressure injuries? Answer: pressure injuries are caused by impaired blood flow, resulting from limited mobility, poor nutrition, and unrelieved pressure or friction. Question: what are the risk factors for developing pressure injuries? Answer: limited mobility, poor nutrition, and unrelieved pressure or friction are key risk factors. Question: how does necrotic tissue affect wound healing in pressure injuries? Answer: necrotic tissue hinders healing by promoting bacterial growth and acting as a barrier to reepithelialization. Question: how should infected wounds be treated? Answer: infected wounds should be managed with drainage of abscesses and sharp excisional debridement of all devitalized tissue until granulation tissue is present. Question: how should non-infected wounds be managed? Answer: non-infected wounds can be treated with enzymatic, mechanical, or autolytic debridement, although these methods may be slower. Question: how should wound dressing be selected for pressure injuries? Answer: selection depends on wound type. Transparent films, hydrogels, alginates, and hydrocolloids are all effective options. Question: what types of dressings are used for different wound characteristics? Answer: hydrogels are used for deeper wounds with minimal exudate, alginates and foams for heavier exudate, and hydrocolloids for moisture retention and autolytic debridement. Question: when are systemic antibiotics indicated in pressure injuries? Answer: systemic antibiotics are indicated only when there are clinical signs of infection, not for superficial contamination. Fungal skin and soft tissue infections. Question: how do fungal skin and soft tissue infections differ in immunocompromised patients? Answer: secondary opportunistic fungal skin and soft tissue infections are more common and carry higher mortality in immunocompromised patients. Question: what are the risk factors for invasive fungal skin and soft tissue infections? Answer: risk factors include autoimmune or rheumatologic conditions, hemodialysis, chemotherapy, organ or stem cell transplantation, total parenteral nutrition, critical illness, prolonged mechanical ventilation, and chronic indwelling catheters. Question: can primary fungal skin and soft tissue infections occur in immunocompetent patients? Answer: yes. Primary fungal skin and soft tissue infections can occur in immunocompetent patients, especially following traumatic injury. Question: what defines fungal skin and soft tissue infections? Answer: fungal skin and soft tissue infections are a group of infections affecting the skin and soft tissues, with severity ranging from superficial to deep. Question: how are fungal skin and soft tissue infections classified? Answer: they are classified according to invasiveness, from local cutaneous mycoses to deep subcutaneous mycoses and disseminated infections. Question: what factors influence the severity of fungal skin and soft tissue infections? Answer: severity is determined by the site of infection, route of acquisition, and the virulence of the fungal pathogen. Diagnosis of fungal skin and soft tissue infections. Question: why is early diagnosis important in fungal skin and soft tissue infections? Answer: early diagnosis and accurate pathogen identification are critical for targeted antifungal therapy due to increasing resistance. Question: what is the recommended diagnostic approach for fungal skin and soft tissue infections? Answer: a thorough history, physical examination, and assessment of lesion morphology are essential. Question: what is the gold standard for identifying the causative pathogen in fungal skin and soft tissue infections? Answer: sterile punch biopsies are the gold standard, while molecular-based tests provide faster identification. Question: what diagnostic methods are available for fungal skin and soft tissue infections? Answer: methods include microscopic histopathology, fungal antigen tests, imaging, and biopsies. Question: what fungal antigen tests are used for Aspergillus and Candida? Answer: galactomannan is used for Aspergillus, and 1,3-beta-D-glucan for Candida and Aspergillus. Question: how is systemic fungal infection diagnosed? Answer: diagnosis involves imaging and biopsies of non-cutaneous anatomical sites. Treatment of fungal skin and soft tissue infections. Question: how are Candida infections typically treated? Answer: initial treatment involves echinocandins, with possible de-escalation to azoles. Question: what alternative treatments exist for azole and echinocandin intolerance or resistance? Answer: amphotericin B may be used, but toxicity is a concern. Question: what is the usual duration of treatment for fungal skin and soft tissue infections? Answer: treatment typically continues for 2 weeks after infection clearance, confirmed by negative blood cultures. Question: how do Cryptococcus species cause infection? Answer: Cryptococcus, encapsulated yeasts, cause opportunistic infections in immunocompromised hosts. Question: how is Cryptococcus infection transmitted and disseminated? Answer: infection occurs via inhalation of spores, which spread from the lungs to the central nervous system and then to the skin. Question: how are primary and disseminated cutaneous Cryptococcus infections treated? Answer: primary cutaneous infections are treated with fluconazole, while disseminated infections require systemic therapy. Question: what is the role of Aspergillus species in opportunistic infections? Answer: Aspergillus species commonly cause opportunistic infections in immunocompromised patients. Question: how does cutaneous aspergillosis develop? Answer: Cutaneous aspergillosis usually results from secondary infection via hematogenous spread or direct skin invasion but can occur as a primary infection in immunocompetent hosts with severe burns or traumatic injury. Question: what is the recommended treatment for aspergillosis? Answer: treatment often requires voriconazole for up to 12 weeks and aggressive surgical debridement. Question: how is aspergillus infection transmitted? Answer: transmission occurs through direct contact with soil and decaying vegetation or inhalation of spores. Question: what are the risk factors for fungal skin and soft tissue infection? Answer: poorly controlled diabetes, neutropenia, or trauma increase risk. Question: what is the treatment for fungal skin and soft tissue infection? Answer: treatment involves antifungal agents and aggressive debridement of infected tissue. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.